Good afternoon and welcome to today's webinar, Medicaid Program Integrity, State Strategies to Combat Fraud and Abuse, brought to you by NCSL. All lines have been placed on a listen-only mode to provide favorable sound quality during today's presentation. It is now my pleasure to turn the floor over to Megan Kumlossi. Ma'am, the floor is yours.
Good afternoon, everyone. I'm Megan Kumlossi from the National Conference of State Legislatures, and on behalf of NCSL, I would like to welcome all of you to today's webinar, Improving Medicaid Program Integrity, State Strategies to Combat Fraud and Abuse. Fraud, waste, and abuse in the Medicaid program cost states and the federal government billions of dollars annually. They divert taxpayer dollars that otherwise would be spent on legitimate health care and can even subject patients to ineffective, unnecessary, or harmful testing and treatment. States have primary responsibility for protecting the integrity of the Medicaid program and are on the front lines in the fight against fraud. Today, we are very fortunate to have three experts joining us to discuss state efforts to prevent, detect, and deter improper practices and recover improper payments. New York Senator Kemp Cannon will open, followed by Ken Yon from Florida's Bureau of Medicaid Program Integrity and Matt McKillop from the Pew Charitable Trust. Our webinar today will conclude with a question and answer session. Please note that you will not be identified when you ask a question, nor can other participants see what you have typed. As a reminder, you may participate by clicking on the Q&A button and typing your question. We will also post the PowerPoint presentation and an archive of the webinar on the NCSL website next week. At this point, I'm pleased to introduce our first speaker. Senator Kemp Cannon was first elected to the New York Senate in 1989. He is the chair of the Standing Committee on Health and chair of the Budget Subcommittee of the Republican Conference. Senator Hannon is the author of the New York State Health Care Reform Act, worked on the Patient Health Information and Quality Improvement Act, and in 2011 was included as a key member of Governor Cuomo's Medicaid redesign team. Hannon's commitment to health policy is also evident in his involvement with NCSL. He is a former chair of NCSL's Health Committee, currently serves on NCSL's Federal Health Reform Implementation Task Force, and co-chairs the Project for Transforming Healthcare Through Technology. Senator Hannon joins us in the midst of session, and we appreciate him taking the time to share with us a little about New York's experience with Medicaid fraud and abuse. Please go ahead, Senator.
It's afternoon here in New York. Good afternoon. Welcome, everybody. Thanks for having me. I just want to do a little bit of an overview. The other speakers, Ken will, I think, add to this, and as will the gentleman from the Pew Trust. But I want to do an overview of what we've had to deal with in regard to Medicaid fraud. We start off with the fact that the federal government requires that there be one designated agency in each state to be the Medicaid agency. And not necessarily in the same place, but usually there will be a requirement that there be a program integrity unit. Usually that's the unit that looks for Medicaid fraud. In addition to that, there is, and usually located in the Attorney General for a state, is a Medicaid fraud control unit. And those are the two, or generally the two mainstays for going after Medicaid fraud. Now we do have a whole layer in regard to health fraud that comes about from the federal government, primarily the Inspector General, but with the addition of the Affordable Care Act, we have the RACs, which are doing regional audits, and those have brought a new layer of fraud detection and misuse to the Medicare area. We also have, frankly, the longstanding fact that each of the respective regional attorney generals of the Department of Justice can bring actions in regard to Medicaid fraud. And in fact, there was just one, it wasn't for Medicaid, it was for Medicare, one action brought this morning by the U.S. Attorney for the Southern District in New York, alleging multiple millions of upcoding and false billing and appointments and interactions between physicians and patients, all in the Medicare program that just didn't exist. I bring that up as a point that we have in New York a continued ongoing temptation to people who would commit fraud. We have one of the largest programs in the state. Partially, it's a large program because we have figured out how to Medicaid much of our mental health budget. Whether or not it's a good thing or a bad thing, it's a fact of life, and our per capita, if you just take everything we spend in Medicaid and divide it by our population, our per capita is far, way and above any other state. And obviously, this is a big temptation for people who feel that there's a way to create fast money. 6 years ago, my colleagues and I had embarked on a way to apply a better system to deal with Medicaid fraud. We looked at around the nation, and we found that in Texas, there was a Medicaid Inspector General appointed by the governor, a person of great talent in regard to white-collar crime, and we felt that that was a good model. We had hearings in the state, and the irony is that the governor's office, at that point a governor of my own party, had people from the Medicaid Program Integrity Unit in the Medicaid agency come and talk about how good a job they were doing. And we had people from the Attorney General's office, from the Medicaid Fraud Control Unit, come and tell us what a great job they were doing. Well, this did not match the evidence that we had by stories, and we went out and did a little sleuthing. We did a far better preparation than we had done in the first hearings to get some demonstrations of Medicaid fraud going on in the state. And we did. And it turned out that some of the starkest examples were in the rural counties of New York, maybe not as rural as someplace like Idaho or Montana, but it's still the rural counties of New York. And that was one great need. And we also asked for the Texas Inspector General to come to New York. He did, and he testified as to the extensive activities he had, with one of the great strongest recommendations being that if we ever did it in New York, it'd be a direct gubernatorial appointment. Well, it took a little bit of doing and legislative negotiation, but by 2007, we had a Medicaid Inspector General. And so we added, and basically, that became a outgrowth of the Medicaid Program Integrity Unit, but although we still kept that. And we also, along with the Medicaid Inspector General, added some provisions to our criminal laws, providing for healthcare fraud and providing for when individuals can be charged with that as to the degree of knowledge. Because sometimes when you were dealing with corporations, it would always be, no, that's what my boss said, that's what my boss said, that's what my boss said, and you never get to a responsible person. A few years after the enactment of the Inspector General, now with a different governor, we had the proposal to add New York's version of a False Claims Act. Now, there is a federal False Claims Act, and we added a state version. And what this basically allows is that an individual who feels there is fraud against the government can, by various steps, interact with the state or interact with the federal government, ask them to bring a claim. In some cases, they're able to bring it on their own. But if a claim is ultimately brought and prevails, that the individual who's found this fact situation can recover 10 to 30% of the monies that have been found to have been fraudulently obtained from the government. So this is a very potent weapon, and New York embarked on its Inspector General with a very active Inspector General, a fellow named James Sheehan, who was recruited from the U.S. Department of Justice from the area around Philadelphia, where he had been in some of the leading cases, especially in recouping monies from the pharmaceutical companies in regard to what they would admit were not claims and practices not in compliance with federal law. This, there was obviously a great deal of reaction from the community of providers who provided Medicaid as to what they were doing in regard to fraud, waste, abuse, but the initial Inspector General was getting a near recovery of almost $1 billion a year in actual cash coming back. We have roll forward. We have a new governor focused on the Medicaid program and appointed a whole task force to reform Medicaid. New York has and is in the process of changing over much of Medicaid finally to managed care. We had about 50% of New York's Medicaid and managed care for physical health. We're now moving into managed care for the long-term care system and for nursing homes and for home health care. Much of the population with special needs, such as developmentally disabled or people with substance abuse problems. Basically, 100% of the health care will soon come through managed care. Not easily, with difficulty in transition, et cetera. And along with that, a global cap for the budget that's spent so that if the sum total of Medicaid goes above this cap, you can recoup monies. And that cap has been a potential and actual hammer to the expenditure and allowed for much recovery from Medicaid providers when the rates have been changed and retroactively applied. But the interesting part I bring up all this discussion is, you must be going ahead pretty well with your Medicaid fraud. No, we have a congressional committee taking a look at New York, compiled lots of news stories about Medicaid fraud still ongoing in New York. And I looked at the report when it came out some weeks ago. And sure enough, then I started to look again at what our Inspector General was doing. Now we have a new Inspector General. And the rate of recovery has gone down to about $300 million a year. The number of comments, obviously, from ex-Medicaid fraud investigators that had appeared in the papers was they felt it was far too slow. So we are going to reinvigorate going back and taking a look and at the level of activity of the Inspector General, because we don't feel that it's sufficient. And the other thing that we want to do is take a lead from what's been actually put in practice by South Carolina, is an ongoing evaluation of the Medicaid program as a built-in part of a program, not just something that's a one-shot, not just something that's a Inspector General audit, but rather on the outside of government, someone to take a look at how well we're doing, what we're doing, how well the care is being delivered, what's the quality of the care being delivered, is there overlap, and so it wouldn't be a one-shot audit, and we feel that that's a necessary element. We got close to it when we did the reform team for the governor 2 years ago, but that's 2 years ago, and when you're spending $54 billion of state, federal, and local money each year on Medicaid, there's no way that you can be complacent about it. So that's been as quick as I can. I probably got over my minutes by one or two, as quick a summary of what we're doing in New York. And I heartily recommend continued examination of each state's Medicaid program, because you need the confidence of your constituents and voters in a program that spends a lot of money.
Thank you very much, Senator, and thanks for squeezing us into your busy schedule. Next, we'll hear from Ken Yon. Mr. Yon is Interim Bureau Chief of Florida's Bureau of Medicaid Program Integrity. He has worked on Medicaid program integrity in Florida for nearly 2 decades. Prior to fighting Medicaid fraud, Ken spent 14 years as a pharmacist, 6 years in the Florida Office of Comptroller, and also worked in state Medicaid pharmacy services. He holds an MBA from Nova University and a Bachelor's of Science in Pharmacy from the University of Florida. Please go ahead, Mr. Jan.
Okay, the slides were up here up.
Hit next.
Okay. First of all, thank you very much for allowing me to present today. I'd like to tell you that the sky in Florida today is very, very blue, and the sun is very, very bright, and we have temperatures in the mid-50s for all you guys up north. I want to go over what our program entails, some details in the short time that I've got. First of all, the reason we want to have a Medicaid Program Integrity Bureau is, first of all, we want to protect the Medicaid recipient, the program, as well as limited dollars. And you're going to hear me talk quite a bit about collaboration today. It's not just Medicaid programs' duty, it's everyone's duty to fight Medicaid fraud, abuse, and waste in the Medicaid program. Collaboratively, I wanted to talk to you about who our partners are, or some of our partners at least. We have a great working relationship with our Medicaid Fraud Control Unit. I wanted to tell you one of our best practices we have, and we've shared it around the nation, is we have a bi-weekly meeting with Medicaid fraud, and we brief them on cases that we intend to make referrals, and that is done very well for us. Inside ACA, our partners are, of course, Medicaid. We have a licensing entity, HQA, and, of course, Medicaid Program Integrity. And inside ACA, we do enrollment, we do policy, we do system claims edits. Like I said, there were some licenses that, of course, we do Medicaid Program Integrity activity. We're also very active in formulating statutes and rules and working with the legislature in doing that. We have a great working relationship with CMS. Florida was one of the pilot programs when the MIG and the MIC started up in 2007. We're also very supportive of the MII, the Medicaid Integrity Institution, which is a great facility, and we're very proud of that. In regards to other regulatory entities, the licensing entities, Department of Health and HQA, we have a good working relationship with them, and we make referrals to those as well. Our detection is basically, it can come from any particular place. We can get complaints, we observe other regulatory announcements or actions. We have interagency bi-monthly meetings with Medicaid fraud, the licensing entities, and other people that are affiliated in some manner with Medicaid recipients. We also attend NAPI. We're part of the TAG group, the Technical Advisory Group. We also have instituted what we call a quad state conference call, and we communicate with California, Florida, New York, and Texas, and on a frequent basis. We have incoming referrals. We also have someone that peruses the newspaper articles and ads as they come in daily. We have our own detection tools. 1.5, this won't mean anything to you, but these are detection tools that we built. The 1.5 is basically it's an increase in payments. If someone's payment on average is increased more than 1.5 times an average, it'll pop up. Early warning is just a threshold report on dollars being paid. We have investigators, situational analysis. They may be looking at billing or policy or coverage. They analyze that, and they'll go into the database and pull up leads for that way. We also allow the investigators to do what-if ad hocs. That's very important for us. We've found quite a bit of leads for that. Part of our FEMIS system, or our fiscal agent system, is a database DSS profiler, which works on some statistical modeling. We get leads from Medicaid. We have a great partnership with the Medi-Medi partnership. If it's going on in Medicare, it's probably going on in Medicaid and vice versa. We also send out 3 times a year explanation of Medicaid benefits. It's 100% review right now, and it goes out 3 times per year to everyone that got a service. We also learn from our PERM evaluations, and one of the things that we do is when we're looking at a provider, if the provider shuts down, we'll follow those recipients to the next provider, which also often leads us to very good leads. And we also notice prescribers that are not enrolled in Medicaid. Those provide very good leads for us as well. And we have a hotline here in Florida. This is basically our menu. Florida does 3 things. We detect, we have prevention, we have managed care compliance, and we have recoupment. On the prevention side, we conduct detection on-site visits. We'll actually go out into the field and look at providers. We do collaborative field initiatives. Now this will invite the licensing entities, we'll invite CMS to come down, us, Medicaid. We'll have an issue and we'll go out into the field, and in 1 week's period of time, we'll look at a large number of providers as well as prescribers, as well as going out and interviewing recipients. That's been a great prevention initiative for us. We conduct prepayment reviews. We don't terminate, but we recommend terminations. We recommend limitations of prescribing rights. If we've got a doc out there that we feel like his script should not be honored, we'll limit his scripts and they'll be denied when they come through the program. We, of course, do referrals to Medicaid fraud, licensing entities, FDLE, et cetera. We also do credible, that should be allegations of fraud withhold. That's a 25A. If, for instance, Medicaid fraud arrests someone, we'll put them on a 25A. But we'll also are abiding by, you would be interested to know, the Affordable Care Act under Section 6402, Paren H, Paren 2, requires us to withhold money when there is a credible allegation of fraud. We work with Medicaid fraud control on that. We do self-audits as a prevention mechanism. We do prior authorization suggestions to Medicaid, prior authorization in the claims payment system. We recommend recipient lock-ins. Right now they would be locked into a pharmacy, and I believe we're looking at locking into doctors, or that's being under consideration. We also do sanctions. We have a new sanction rule and updated sanction rule. We've had a sanction rule since about 2005, and we apply fines, also suspensions and terminations. Education is a prevention issue we do, and when we conduct our business, we see policies that need to be updated or edit recommendations in the claims payment system that need to be implemented. We'll make those recommendations, as well as legislative recommendations. On the recoupment side, we develop overpayments and audits, and in most instances we'll have a final order, and we do post those out on the website for public view. Self-auditing, we'll process the self-audit processes that come in. We do paid claims reversals. We have individuals that are observing claims as they come through the system, and it's a real-time system, and we'll contact the provider, and we'll ask that provider to evaluate that claim that came through the suspect, or provide us information and let us take a look at it, and a lot of times they'll reverse the claim and rebill it appropriately. Our Medicaid program does credit adjustments, and we also have a third-party liability program, and MPI also piggybacks, and they do some work for us in that arena. Other points of interest, when an application undergoes a background check, we also look at a previous program history check. Now, why is that important? A provider may have terminated their enrollment, but may owe us an overpayment, and if those associated persons attempt to come back into the program, we'll catch that, and they will not be able to enter the program, or they at least have to make payment of the overpayment. Terminations that we do are based on both the provider or the associated person's event. If there's an associated person that has a background history that is suspect, we in fact will terminate that provider as well. Our terminations may be contractual or for cause. We do both. Contractual is we're just terminating the contract. For cause, they actually have hearing rights. We do some of both of those. Florida takes like action if another state or a federal entity or Medicare has taken an action against a provider or an associated person. Florida will also do the same thing. If they're terminated in New York and New York State, and once we get that information, we'll also terminate them in Florida. We terminate if they fail to make payments on the overpayment. We also, as mentioned previously, one of the big prevention methods is our sanction of a fine, and we also recover costs when we do an audit. And that would be not only the audit, but litigation costs, peer costs, we'll recover that. And we start recovering overpayments if a provider asks for a hearing. We now start recovering that overpayment immediately or within 30 days of them asking for the hearing. In the past, we did not do that, and they would ask for a stay and ask for a stay and ask for a stay, so that overpayment will stay on the books. What this does is, first of all, it brings it to the table, and a litigation case seems to advance much faster, and also we start taking our overpayment back right away. As I mentioned previously, we post our final orders on the website, and that would have the sanctions involved, and that's a deterrent. I will guarantee you about that. We also started a program that's been about a year ago now, give or take. It's a telephonic home health services delivery monitoring. That's on home health services, and basically those services are home health visits, private duty nursing, and personal care services. When the individual goes in to perform those services, they have to phone in, or there's another advice that they have to make contact, but they're actually present on site. When those services have been completed, they have to sign out with us, phone in and sign out, and also indicate what services they provided. That was started as a pilot in Dade County, which is in Miami, and it is now being expanded, or has expanded, to about 33 counties in Florida. There's 67 counties right now in Florida. One other thing I didn't mention in the slide here, but our licensing entities also assist us in collecting overpayments. If a provider comes back and tries to renew their license, we have communication with the licensing entity, and they assist us in helping that person or the provider come to terms on the overpayment with us. And we're currently moving into managed care on a big way, and we just started, and we're starting to get into the compliance area on that. Now, I wanted to show you some of our results that we've done. We have an annual report. I'll give you a link to that at the end of this conclusion. But this first slide here shows our site visits, and that's certainly a deterrent when we go in and do a site visit. Shows the type of provider we went into, et cetera, et cetera. For assisted care services, we made 303 site visits during our fiscal year 11 and 12. This is the number of referrals that we've made. A lot of these are licensing entities. The Department of Health are licensing entities for professionals. Health HQA, Health Quality Assurance, is a licensing entity for healthcare. And the MFCU referrals, et cetera, et cetera. So this is our recoveries. I'll point to the far right side. This is actually money that we brought into the door. And 10 and 11, we had a great year. A lot of things came together. $83 million brought in. 11 and 12, $62.2 million. And it talks about where those dollars came from. This is our prevention dollars. We're talking about doing site visits, the focus initiatives, et cetera, et cetera. We brought in, we prevented $27.9 million in fiscal year 11-12. This is our sanction or contract issues that we brought money in fiscal year 11-12. We brought in $6.1 million. You'll notice the previous year was just a little under $1 million. Well, we had upped our sanctions and fines and made a change in 2010 on that. Our return on investment has been very, very good, very high. In 11 and 12, our return on investment for the Medicaid for Medicaid program integrity was 6.8 to 1. And a lot of this have gone pretty fast, but we have a annual report that we produce every year. It comes out in December of each year, and the link is at the bottom of this particular slide, and you can read in more detail of my concise presentation today.
Thank you very much, Ken. Next, we'll hear from our third and final speaker. Matt McKillop is a senior researcher on the State Healthcare Spending Project, a joint initiative between the Pew Charitable Trust and the John D. and Catherine T. MacArthur Foundation. The project analyzes healthcare spending across the 50 states and examines the factors driving these costs and the effectiveness of efforts to manage them. Mr. McKillop coordinates the project's research on cost containment strategies. He holds his master's degree in public policy from the George Washington University and a bachelor's degree in political science from Kalamazoo College. Please go ahead, Matt.
Thank you, Megan, and thank you, NCSL, for the opportunity to participate in this important discussion. I also want to thank Senator Hannan and Mr. Yan for both of your informative presentations. So, as Megan said, my name is Matt McKillop, and I'm a senior researcher with the Pew Charitable Trust on the State Healthcare Spending Project, which is a joint initiative with the MacArthur Foundation. And our project helps policymakers better understand how much states spend on healthcare, how this amount is changing over time, and how states can manage costs while improving health outcomes. And it's primarily our interest in this last piece, cost containment, that spurred us to conduct research in this area of Medicaid program integrity, because we believe that states can save money and help ensure that Medicaid's limited resources are supporting legitimate care for the millions of Americans who count on the program. So just to take a quick step back and sort of explain the genesis of our project, really our project is built on the belief that as the state leaders continue to shore up their balance sheets in the years ahead, they're going to need good information on healthcare spending that consumes a substantial and growing share of their budgets. And so I think that this graph is a good illustration of that. And this comes from an analysis that we did last month of CMS data that comes out every year on annual health spending. And what you see here is that state and local government healthcare spending as a share of revenue increased from 16% to 30% from 1987 to 2011. Now, I want to be clear, our project doesn't take a position on whether that is right or wrong. And there's not one right answer for how states or localities should respond to this trend, but I think it does speak to the increasingly challenging task that lawmakers have of meeting their residents' healthcare needs along with other priorities like education and transportation. So 2011, for example, while total U.S. healthcare spending grew slowly, and it was the third consecutive year that that had happened, spending by state and local governments increased by 10%. And after adjusting for inflation, their combined healthcare expenditures has increased by 241% between 1987 and 2011. And that's the earliest year that data are available. So I think the point is that leaders are going to need good information about what is being spent and how money can be saved without harming residents. And, you know, this brings me back to Medicaid fraud and abuse. So in 2010, an estimated $11 billion, 9% of state Medicaid funds was absorbed by improper payment. This includes fraud and abuse, as well as unintentional mistakes, such as sending money to the wrong recipient. And while fraud and abuse is only one component of this $11 billion, I think it's fair to understand that the toll on Medicaid budgets is substantial. So to help states improve their efforts to combat this in their Medicaid programs, our project has built a first-of-its-kind database that makes it simple to learn about anti-fraud and abuse strategies that are being employed. The database compiles and categorizes promising practices that were cited by CMS in the agency's reviews of state program integrity efforts. Some of you might know about these reviews. They've been happening for about 5 or 6 years, and CMS's Medicaid Integrity Group conducts them on a rolling basis. They do about a dozen states per year, and within a larger report are practices that states report to CMS that they believe are standout and particularly effective. And then among those, CMS also sort of does additional research and highlights a few which it believes are especially noteworthy and practices that other states should review and consider emulating if they aren't already. So what we essentially tried to do is take what we think are really good information, but it is fairly inaccessible because it's spread out over 85 separate documents, and trying to pull that into a one-stop shop, essentially, where users can filter results by state or by a group of states, as well as by category of intervention, or both. And I'll talk a bit more about those categories of intervention in a second. We also wrote an issue brief to correspond to the database, which provides an overview of how and at what point in the billing process states protect the integrity of their Medicaid programs. So both the database and the brief can be found on our website at www.pewstates.org/Medicaid-fraud. You can also find it at the URL at the bottom of this slide. Let me say a bit more about these categories of intervention and walk through some examples from the database. So fraud and abuse can obviously be committed by both Medicaid providers and patients. But in our review of federal data, we found that the vast majority of state strategies are focused on providers. This may or may not be surprising to the people on this webinar, because we tend to hear about fraud and abuse committed by beneficiaries. But one reason we think for this focus on providers is that the magnitude of dollars that has the potential to be lost by problematic providers or suppliers who submit fraudulent claims across hundreds of beneficiaries is quite a bit higher than any one beneficiary is capable of perpetrating. So for those worried about losing Medicaid money to fraud and abuse, the focus on providers must at least match that of beneficiaries. And generally speaking, states have 3 opportunities to reduce fraud and abuse among providers. The first is screening providers before and after they are accepted into the program. The second is reviewing claims before they are paid. And the third is reviewing claims after they are paid and recovering improper payments. So drawing on the reviews of state practices by CMS, our database organizes state approaches by these 3 categories, as well as a 4th that cuts across categories, and then further breaks them down into 13 subcategories, which you can see in these boxes. Now, this is obviously a simplified way to look at the process, but we believe that boiling the process down into this sequence is helpful for getting a clear picture of state opportunities for intervention. So let me sort of walk through these opportunities one by one and provide some examples. The first stage is provider regulation, and this means thoroughly vetting providers with background checks and similar procedures to discover whether they've committed crimes before, particularly Medicaid or Medicare fraud, in the same state or other states before they're accepted into the Medicaid program, and then continuing to monitor them thereafter. And there are a host of good examples of this in our database, but in honor of my colleague from Florida, I thought I'd briefly discuss one from that state, where Florida has automated their manual license verification process to allow daily checking of provider licensure information and weekly checking of facility licensure information. This allows Florida to suspend providers whose licensure data on file doesn't match new information, and to notify a provider proactively that an upcoming suspension will occur if a license due to expire in 60 days is not renewed. This is important because licensure problems can be a first sign that something is amiss. So the automated system frees the state from a manual, labor-intensive, paper-based process that can cause delays in receipt of notification and historically left the state exposed to potential overpayments and costly recovery efforts. The second stage is prepayment review. This occurs once providers are in the system, but before money goes out the door. Here, states must review claims to confirm to the best of their ability that the services being billed for actually occurred and that they fall within the state, within what the state would consider to be appropriate care and what it is authorized for providers to do. New York has an intriguing practice in place for several years whereby it requires certain providers to prove that patients were actually at their offices by mandating that patients swipe their benefit cards on every visit. Additionally, select providers, for example, a physician ordering a prescription, must post orders to the state's electronic claims system before another provider, a pharmacy, can process and bill the transaction. According to the state itself, these programs generated a combined cost savings of $683 million from 2008 to 2011. So, I think this is a very straightforward way to make sure that the care that is being billed for at least could have happened because the patient was in the office, and that the medication pharmacies are dispensing were prescribed by an authorized physician, which also has the added benefit of helping to prevent substance abuse. A third example, which doesn't appear to be showing up on the slide, is the time when states have the opportunity to address fraud and abuse occurs once reimbursements have been made. And this is the time that states have the most information at their disposal to mine data at a systemic level and attempt to identify large and small patterns of faulty billing. The trouble here, of course, is that money has already gone out the door. So to the extent that states can effectively manage a pool of reputable providers and review claims before payment, they can save themselves time and money at this late stage. But that said, not every instance of fraud and abuse will be averted. So this stage needs to be executed effectively. And one great example exists in Illinois, where the State Healthcare Agency's Office of Inspector General developed an in-house system that utilizes cutting-edge predictive modeling techniques. And the system detects aberrant provider behaviors at the earliest possible time. So once detection occurs, it creates a comprehensive provider profile report that offers a consolidated snapshot of provider patterns and activities. This report gives state officials quick access to complete, up-to-date information on providers of interest as they plan investigations or audits or quality of care reviews. Finally, there are cross-cutting measures that underlay the three stages I've discussed, such as effectively working with internal and external stakeholders, and homing in on providers that states believe to pose a higher than average risk of fraud and abuse. A good example of high-risk provider targeting is in place in California, where the state has developed a Medicaid payment error study to identify provider types at greatest risk for payment errors and conducts weekly random audits on various provider claims. The state uses the results to develop new fraud control strategies and determine how best to deploy limited program integrity resources. And in the case of California, this has led to increased scrutiny of pharmacies and adult day health centers. Now, I want to touch on a point which I think is important. And by virtue of participating in this webinar, I think we all agree that combating fraud and abuse is essential to the sound fiscal management of Medicaid. But I think we all have to realize that states have to maintain a roster of providers who can adequately care for the residents who depend on Medicaid. And the vast majority of providers are lawful and honest and well-meaning. And they take reimbursement rates that are lower than they can get in the private marketplace to care for a very vulnerable population. So states need to strike a balance between being stringent and ensuring that money is going where it needs to go, while at the same time not overburdening providers who are acting just as the state would want and discouraging them from accepting Medicaid-insured patients. This is a tricky but important balancing act that every state needs to walk. Before I finish up, I just want to touch on something that is likely on many of your minds, and that is implementation of the Affordable Care Act. So many of you probably know that ACA included several measures related to Medicaid program integrity, and I thought I'd just list some of them. First, it enshrined a more targeted approach to screening, which I alluded to during the cross-cutting opportunity. And what has essentially happened is that CMS has designated each provider or supplier category into one of three levels of risk: limited risk, moderate risk, and high risk. And each level of risk now corresponds to certain screening procedures. And I think that this is going to help states target their program integrity resources. Second, state Medicaid programs now have been empowered to pause enrollment of a high-risk category of providers or providers within a geographic area for at least 6 months, as long as they can prove to CMS that care for patients isn't going to be adversely affected. So if states are seeing a rise in provider types that are submitting aberrant bills, this allows them to sort of freeze that until they have the opportunity to look into that and then decide to exclude those providers or move forward. Third, and Mr. Yan alluded to this earlier, state Medicaid programs may now suspend payment to providers pending the investigation of credible allegations of fraud. Fourth, states now have to work with at least one Medicaid recovery audit contractor, or RAC, and these are private entities that review paid claims and earn contingency fees for improper payments they retrieve. RACs have been used historically in Medicare, and CMS believed that they were successful there, and through the Affordable Care Act tried to bring them over into Medicaid. And then finally, states are required to terminate Medicaid providers whose Medicare billing privileges have been revoked by the federal government or who have been terminated for cause by another state. And to help ease this process, CMS has launched a web-based application that is meant to ease states' efforts to share this information, which I think will be tremendously helpful as states continue to screen providers and then monitor them. So the last thing I'd leave you with is some data to help explain one of the reasons this issue has been attractive to us from a fiscal standpoint. There is emerging evidence that states that combat Medicaid fraud and abuse well can achieve an impressive return on their dollars spent. So according to CMS estimates, states spent $394 million on program integrity efforts in federal fiscal year 2009. And they recovered $2.3 billion. If you divide that, you get a ratio of about 6 to 1. And this ratio wouldn't capture averted fraud and abuse achieved through solid provider regulation and prepayment review. So it's possible that the return may actually be higher. This suggests to us that as states look for ways to save healthcare dollars without negatively impacting their residents and potentially even improving their health outcomes, combating fraud and abuse in Medicaid programs is certainly something that every state should be committed to getting right. That concludes my presentation. I want to thank NCSL again for inviting me to participate, and I encourage everyone listening to visit our website, pewstates.org/healthcare spending, all one word, where you can find our database and brief. We also invite feedback from participants in the webinar about the work we're doing in this area and healthcare in general, because it's important to us to know how we can be most helpful to policymakers. I can be reached at 202-540-6398, and my email address is mmckillop@pewtrust.org, and that contact information is available here on the last slide. Thank you very much.
Thank you very much, Matt, and it looks like that database will be a great resource for policymakers. At this point, I'd like to thank our three wonderful speakers, Senator Kemp Hannon, Ken Yan, and Matt McKillop. And now we'd like to open the floor for participant question and answers. As a quick reminder, to ask a question, just click on the Q&A button and type in your question. Please make sure you ask your question to all panelists, and remember that the questions will remain anonymous. Our first question is regarding payment reform. And I think we'll maybe start by directing this to you, Ken, and then if others have input, please feel free to respond. What does payment reform, such as bundled payments, medical homes, et cetera, mean to fraud, waste, and abuse efforts? Does it make prevention more difficult or easier? And can states do anything as they implement payment reform to aid with Medicaid fraud and abuse efforts?
Well, my response to that would be, if you bundle things, you might be able to cover some things up there. It certainly would make it more challenging, probably for us, you know, from a program integrity standpoint.
Okay. And another question is, are there specific areas of Medicaid where fraud and abuse is more of an issue, or where my state should focus its efforts? And Ken, I think we'll direct that back to you. Has Florida had specific experience with fraud kind of concentrated in certain areas?
Well, yes, we have, but in our detection mechanisms that we use, we look at all provider types. I would probably say some of the non-licensing entities seem to have questionable issues, probably more so than some of the others, such as someone with a professional license, and that's on the line. They may have less of an issue, but it doesn't mean they don't have issues. They do have issues. So we had great impact on the home health agencies here in Florida, starting back in 2007, 2008. We had a lot of concentration in that particular area, and those expenditures have gone down quite a bit with the attention we've given. That would be one particular place we've looked at quite often. But we look all over. We've got limited staff, so we're looking for aberrations and our best return on investment, so we do look all over.
Great, thank you. This next question I think we'll direct to Senator Hannon, if he's still with us. Senator Hannon, are you there?
I'm sorry, the senator had to run off to session.
Okay, thank you. Well, then between Ken and Matt, hopefully we can answer this. The question is, states that the Office of Inspector Generals are under tremendous pressure to back off once they start recovering significant amounts. What efforts have been most successful at insulating OIGs from political pressures to ease up on providers?
Well, I can address that for Florida. We operate under the OIG model, and in 2009, we made a tremendous leap forward. The legislature made a tremendous leap forward in passing what we termed at that time Senate Bill 1986, and we've gotten very good support, and we've implemented a lot of the changes that I mentioned on my slides today were implemented, and we've also raised our issues on sanctioning. So we've gotten good support here in Florida, and we, like I said, we work very closely with our partners as presented in the presentation. So we have not been interfered with here in Florida.
Thank you. Matt, I think I'll direct this next question to you. And the participant is asking if you know anything about New York's program that involves card swipes that saved about $683 million. And they're wondering whether that program had significant upfront costs. Did you find anything about that in the CMS reviews?
We haven't looked in great detail in terms of the upfront costs, but I think it's fair to say that in order to establish the IT infrastructure to make sure that every provider has the swiping device where beneficiaries would swipe their card, and then also in terms of the post and clear, where providers can put in their information about Medicaid that they have prescribed. I think it's fair to say that obviously, that there would be some cost to setting that up. I would be happy to work with this questioner to find out more information about it if the person wants to contact me directly. There are documents that New York has where we found the savings information that might speak to that question.
Great, thank you. And I think this will be our last question. Are any states funding their fraud and abuse efforts either wholly or in part from recoveries? And maybe we'll have you both answer that. Ken, if you want to start.
I sure will. We fund ourselves through the Medical Trust Fund, and our particular funding for Medicaid program integrity comes from that particular fund. So as I indicated, we have a 6.8 to 1 ratio on cost. So, we brought in almost $900 million, and our cost was I don't know, I'm guessing here probably about 12 or 13 million. So we fund ourselves through the Medical Trust Fund here in Florida.
Okay. And Matt, did you find anything in the reviews?
There are certainly a number of states that do that, but one thing I would point to, and I alluded to this, is that the RACs that have been implemented are entirely funded based on a contingency fee from monies that they recover. So in this case, it certainly seems like CMS is moving states in that direction to, at least on the recovery side, entirely fund the kind of data mining efforts and those actions by recovered dollars. I would also say, real quickly, to the question earlier about high-risk providers, we haven't done work to kind of identify groups specifically, but within the CMS regulations I mentioned, CMS has actually designated several provider types which it believes have a history of high risk for fraud and abuse. And so if the questioner wants to contact me directly, I can point to the regulation that includes that information.
Great, thank you. And thank you all for participating today. I'd like to thank our speakers and all of our attendees for your time. As a reminder, an archive of the webinar will be available on NCSL's website by the end of next week, as will the presentations in a PDF form. So some of those slides that didn't come through, you'll be able to access as of next week. I'd like to direct your attention to 2 upcoming health webinars that NCSL is putting on. Those are advertised on your screen right now. And again, I'd like to thank everyone. If you have additional questions, please do feel free to contact myself, Megan Komlossi at ncsl.org, or go ahead and contact any of our speakers. Thank you very much.
Thank you. Ladies and gentlemen, this does conclude today's teleconference. We thank you for your participation. You may disconnect your lines at this time and have a great day.